Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
We are here with Dr. Tina Bhutani, one of our favorite key opinion leaders to have on our podcast. And she, of course, everyone knows her well. She's the CEO of Synergy Dermatology in San Francisco, an associate clinical professor at UCSF, and a previous co-director of the UCSF Psoriasis Center. So thank you for joining us again.
Thank you for having me again.
And I'm really excited for today's episode because I feel like it's an area where we almost think it's simple, but it's actually not simple. And it's an area where we have a lot of questions in clinic. And that's the world of topical non-steroidals, because for a long time we've known our patients don't really love steroids. We don't love them on steroids long-term either. And then sometimes there's a lot of counseling about, well, if you're going to use this one, it's for this length, and then you move on to these things. So we understand the whole world of the steroid world, which we could talk about in a second too. Then there are the non-steroids, which we kind of understand, but we've kind of always put them in like different categories. And today we're talking specifically about roflumilast. I got through saying that. That's one of those tough ones. Also, actually,
you had to practice it a few times.
I had to practice that a few times, but also the brand name, Zoryve, but some patients call it Zoryve. So, we have the key opinion leader on the matter here, but the pronunciation,
99%, I think it's Zoryve.
Zoryve. Okay, so that was really the one thing. That's what we're going with. Dr. Bhutani says Zoryve, so it's Zoryve. But we're here to talk about Zoryve because it's been a game changer in our clinics.
Yeah.
We might not be able to necessarily know how to say the name, but we can. It's when we prescribe it, our patients are doing really, really well with it. And then the other piece what we wanted to highlight is that there are different strengths and different indications, and sometimes that's confusing. And we know in clinic that if you just happen to write the wrong one for the right indication, you're going to immediately get a denial,
right?
Which is a waste of time for you, your staff, your patients. So for many reasons, and actually just a unique mechanism and all of that. We want to talk about, Zoryve
we're going to talk about it all.
So we're going to talk about it all today. So why don't we actually just even dial it back? What do you think about where steroids kind of are, and I guess the drawbacks, steroid withdrawal? Where do you see when a patient comes in and you're thinking topical category, which even our patients on systemics still have topicals.
Yeah. I think, topical steroids, I think, are always going to have a role in dermatology. We're never going to get rid of topical steroids completely for a variety of reasons. But what I think we can get rid of, as you mentioned, is the overuse of topical steroids or using topical steroids inappropriately. That's where things really go wrong, right? And that's when we tend to see things like topical steroid withdrawal, because these are patients who have been using inappropriately large amounts of steroids over large surfaces of the body, and then they stop at cold turkey and they develop these other types of symptoms. So again, I think when topical steroids are used appropriately, they still have a role. But with the addition of these newer non-steroidal topicals, I think it's going to become a lot easier, right? Because now we have options other than steroids that are very effective, that are very safe for our patients, that it's going to immediately kind of make that job a little easier on our part.
Yeah, absolutely. And then the kind of the different ones that we've had over time, there's been the issue of the formulations and how they come, and is it going to sting, and do you still need to use the steroid first, and if you're going to need to use a steroid then I think this type of medication has kind of changed that. And I know way more about the formulation is unique, right? I think that's one of the special things about it.
Right. So as you mentioned, in the past we've had topical non-steroids, right? This is not novel in that way, but the topical non-steroids that we have, if you put it on inflamed skin, things like tacrolimus or even calcipotriene, for example, for psoriasis that we've had for many years. When you put it on inflamed skin or active psoriasis or active AD, it oftentimes causes stinging or burning, or actually worsens the disease. And so we were always taught, right, to bridge into the non-steroids. So you start with steroid for a few weeks, cool down the skin, and then you bring in the non-steroid. But now with these newer non-steroidal drugs, and specifically with Zoryve, the formulation is so well designed that we actually don't have to worry about that anymore. And the data shows that this medication is just so effective even from the onset. So we're not having to do that steroid bridge anymore.
Which is actually huge, because I think changing behaviors is hard.
Yes.
And when we have a paradigm in clinic of, okay, well, this is where you put the non-steroidals, this category. Yeah. Even myself, it took me a while to be like, wait, I don't have to start with the steroid first. Because we do have options where they're no longer just adjuncts.
Yes.
They're like
yes.
go-to medicines.
Yeah. I was just having this conversation. Like, I still remember having that map, like the body map in clinic, like printed out on a handout. And then we would write down, like, this is the medication to use for the scalp. This is the medication to use for the body. This is the medication to use for sensitive areas. And then you would write 3 different prescriptions, potentially have to do 3 different prior authorizations, right? And inevitably, the patient would come back and they're using the wrong medication in the wrong place, right? They're like, oh, I've been using the clobetasol on my face. It works great, but I have acne. You know,
Right. 100%,
And so I think the other great thing about these newer non-steroidals is that it's going to simplify our lives so much because they can use one medication anywhere on the body. We don't have to worry about how long they use it for. There's no time limit. Again, they're safe and they're tolerable. So we don't have to worry about them calling the next day about burning and stinging. So it's going to simplify our lives in so many different ways.
Yeah, I mean, just like decreasing the amount of time I have to explain that diagram, and that by itself is like gold. And then I practice in a large multi-specialty in a clinic, and by the time they've come to me, they've already had a lot of steroids from primary care too.
So they want something new.
They want something new. So I find when they come to dermatology, like they want the newer, innovative therapies. So I think it's interesting for us to just kind of change our mindsets a little bit around that.
Yeah. And I was going to say, when getting back to the formulation, for Zoryve specifically, the vehicles for both the Zoryve cream and the Zoryve foam, they were actually designed for roflumilast. So a lot of times, a molecule is, developed for whatever disease indication, and then they just throw it into the standard vehicle, right? Like a standard ointment, a standard cream. But for Zoryve, the vehicle itself, there was a lot of research that went into how we can maximize the efficacy and tolerability of the roflumilast molecule. So a lot of work went into the formulation in itself. And again, I think that kind of gets back to, the safety and tolerability. And again, just that one simple prescription that you're gonna give to your patients.
No, absolutely. That's such a good point, actually, because I think that's a world that I would say, like maybe in parallel, the cosmetic dermatology world has known for some time that how you formulate something really matters. Like you need to get, not irritate the stratum corneum, you need to get through to where you need to get. You need to have bioactivity, and the prescription world hasn't necessarily always even compounding, whatever it is, you take the active molecule and you just stick it in whatever kind of vehicle. And I think this is kind of one of the first I'm seeing it translate over, where you're kind of getting that elegance of the formulation, plus the added, really higher, like FDA approved prescription, higher level kind of mechanism. So that is unique. I think people need to realize, because sometimes it's hard to know, like when you have a few kind of non-steroids now, what's different, and like why this one, and why, and what patient do you, I think that's the hard thing, like what patient that comes into your clinic do you think about prescribing this versus that, and then the time it takes to explain all these things. So I think that, I really appreciate you going all the little nuances, because in clinic you're busy, you don't know all the latest data. Like it's just interesting to kind of put them in the right categories. And actually, we should probably talk about the mechanism itself, just PDE4 inhibition. So how does it work in general?
So phosphodiesterase 4 is an enzyme that's in a lot of different inflammatory cells. And so Zoryve or roflumilast will inhibit that activity of PDE4. That leads to an increase in something called cyclic AMP. And cyclic AMP, we know, just has, many anti-inflammatory properties, basically. So not only in the Th1, Th17 pathways that we know are important in psoriasis and sebderm, for example, but also in the Th2 pathways, which is why it's also important or approved for atopic dermatitis. So it kind of, has multiple anti-inflammatory properties in many different pathways, which is also what makes it pretty unique in that way.
Yeah, that is pretty unique, because I feel like with our biologic systemics, we've gone so down to the science and really, really targeted.
So
and then
targeted.
Now we're starting to do it with our topicals. We're like, okay, it's getting this pathway and this pathway. So that's really unique. And then putting it in an elegant formulation. I like using it. It's not burning your skin, especially with the kids, right? The children, the pediatric population, you burn their skin once or tingles a little bit, they're not going to let you put a cream on again.
And I think it gets back to the point, I think in the past, a lot of people said, we have our steroids, we don't have to have new innovation when it comes to topical medications. But I think Zoryve really proves that there is a lot of space for innovation, not only in the molecule itself, obviously that was innovative, but also in the formulation.
Yeah. And I think for us, let's say we're in clinic 10, 15 minutes and we're doing the body map and explaining things to people, the amount of time and burden of that, they're dealing with that every day at home.
Yes.
too. So like patients, like when they get confused,
where's my
what
map
to put
and where do I-
where,
yeah,
they come in
yeah.
with like the bags of stuff. It is overwhelming. Like,
Yeah,
I mean, I totally get it.
yeah.
You know, I'm actually the worst compliant patient. Like, and you know, you give me two things to do.
Doctors are the worst
I'm
patients,
the
I
worst.
think, in general.
Yeah. So like, I totally am like under that camp of if you were to give me something and then you tracked if I opened the bottle or not, like it would be not open all that much.
Right.
So like compliance is huge. Like if it's not easy to use,
Yes.
you're not going to do it and you're not going to get the effect.
Absolutely. Yeah. Yeah.
Oh, that's fantastic to cover. Also, actually, so you do a lot of cool stuff, obviously, and you're like a total expert in psoriasis. But one of the things was the consensus statement that just came out on the genital psoriasis. You tell us more about this, but it's the Genital Psoriasis Wellness Consortium, and I believe the consensus statement just dropped, right? Very recently.
It was in the Journal of the European Academy of Dermatology. It just was published in the last couple of weeks. And this was actually, it was a group that was actually put together by Arcutis, which is a company that makes Zoryve, because I think they recognized that genital psoriasis is kind of this special form of psoriasis that patients aren't talking about and doctors aren't asking about.
Yeah.
And so it makes it really tough to treat. I think for patients, you know, genital psoriasis oftentimes can look different than the psoriasis on their skin, right? It's not thick, it's not scaly. And so a lot of times they don't think it's psoriasis. They're like, oh, maybe I have jock itch or maybe I have something else. And so they won't bring it up in a patient. You know, if you ask them, do you have psoriasis anywhere else? They're just going to say no because they don't think it's psoriasis. But if we were to take the time to actually tell them that, you know, the genital area is actually a common place for psoriasis, and it can oftentimes look different than the psoriasis on your other parts of your body, they might be more open to be like, oh, actually, I do have this rash in my groin, or, you know, whatever it may be. So that's one piece of it. And then the other thing is that the doctors, you know, we're busy in clinic. We don't have time to do a full body skin check on every patient. And so again, I just think like increasing the awareness around genital psoriasis and the unique aspects of it. That was the goal of the Wellness Consortium. So.
Yeah, no, that's incredible. We've known that for a long time, that there are such implications when it comes to sexual health.
Yes,
when
absolutely.
you have any skin condition at all in that area. I mean, I have people like, I just recently, even this last week, I had a patient who was like so nervous and was about to show me, you know, like a spot, and it was a seborrheic keratosis.
Right.
And he told me, he was like, oh my gosh, I have been like basically freaking out about this for so long.
Yeah, totally.
And I was like, it's fine. If you want me to take it off, we don't have to take it off. So, and that was like one spot. But if you can imagine, you also have like a larger plaque, and maybe on top of it, you also have itching, discomfort. Like it's a very different mindset. And then also medication wise, we've been a bit limited. Like you mentioned, we used to steroids. It's a whole thing. Again, intertriginous areas. Right. The calcipotriene inhibitors, I used to use them a lot, but they're not comfortable in that.
Yeah, they're not comfortable. They don't work all that well. They're kind of greasy, right?
Exactly. Like nobody wants to walk around with like all this ointment.
Exactly. Yeah. Like all over your underwear. You know, it's just, it's not, I mean,
it's not
like
ideal. Practical things that comes back to the compliance. They're not going to bring it up. Like, well, the last two doctors have given me this and this. And so it's really amazing that the work you're doing there. And then also other special sites. I mean, there's definitely areas that are visible, but there's, like, of course, the genital area we talked about. Palmar. I find like Palmar's an important area.
Yeah, the scalp.
Scalp is so
a
tricky.
Huge area that's so tricky. It's so hard to treat. Very visible for many patients, right? Especially if they have their hair cut short. Even if they have their hair long, the flaking on their clothes and everything else that, you know, goes along with scalp psoriasis. It's a huge impact on quality of life. So it's another area that I think, you know, we tend to undertreat because we think like maybe they can hide it with their hair, but it's actually, you know, an area that we should be focusing better on.
So I find like for these like little hot spots, it's so key to have these like really good.
Totally.
And then actually we should probably go over the percentages, because there's different percentages, different formulations. I know we're talking about the medication like it's just one thing, which it is, but it does matter what formulation something comes in. Like we just talked about, like if it's super greasy, or if you're using a cream in your hair, that's not going to work.
Exactly. I mean, for some people it might.
For some people,
but you want to ask about it. But in general, so now with Zoryve, we have multiple different formulations and multiple different indications, which is great because we have this, you know, huge toolbox, and you can find a formulation for anybody that walks in the door. But at the same time, like you said, it can be a little bit confusing, so it's good to get it straight. So for atopic dermatitis, the indication is, atopic dermatitis, but it's 0.15% cream is what's approved for AD, and it's approved for ages 6 and up. for atopic dermatitis. For psoriasis, there are now 2 formulations. So there's the 0.3% cream, which is approved for ages 6 and up. But there's also now, just hot off the presses, last week got approved, 0.3% foam, which is approved for ages 12 and up for psoriasis. So those are the 2 psoriasis formulations. And then actually Zoryve is also approved for seborrheic dermatitis, which is really exciting, right?
Yeah.
Like, when's the last time we had something FDA approved for the treatment of seborrheic dermatitis? True. It's also the 0.3% foam, and that's approved for ages 9 and up.
Yeah. No, that's
and so it's a little confusing with all the ages, but again, if you kind of get it right and get the formulation right, access is pretty good for these drugs as long as patients are commercially
insured. And I think that's important to know too, because sometimes you might not know why you got the denial, but it could be something that simple. Like maybe you just wrote, it may be your patient writing it for a patient who it's just not quite the age group that's covered, or it's because insurances are looking for a reason to deny it, so right? It is important to just take a minute and just make sure it's like the right indication. I guess the easy way to remember it is the higher percentages for psoriasis and seborrheic dermatitis, and then the 0.15 is for atopic derm. So at least if nothing else, if nothing else after this podcast, remember that 0.3 psoriasis, seb derm, 0.15 for atopic dermatitis, which is really nice to have those kind of options. Seb derm is really exciting actually, because I felt like you just didn't have anything great, especially for that facial seborrheic dermatitis. You never want to put any steroids of any kind. You're always, even the lowest strength steroid you're putting on the face, you're just like, I don't know about this. Atrophy, acne, all the things. And then you would maybe throw in some ketoconazole and you're like, I don't think it's going to do that much. It's not going to do anything. And they always come back and they say it didn't do anything, like the large majority.
But you're just buying yourself time.
Well,
you're like, maybe I can buy myself 3 months.
Anyway, and you could just see the look of their face like, okay, like this is, so
and
that's
foam,
amazing to have.
Like, again, getting back to this formulation, I keep coming back to it, but it really works well in those hair bearing areas. It's really elegant. It really kind of, you can get it right to where it needs to go without it dripping all over your face like a solution or something like that. And they tested it across all different hair types and all different, skin types. And patients were kind of satisfied across the board, which is great.
Which is key. Like if people don't like something, they're not going to use it. There won't be compliance. They're, they're right back in your office. Hopefully they're right back in your office, because some people actually just give up and they like stop treating, which is even
and then
worse.
They'll never come back again.
So these are great solutions. Thank you so much for doing an overview. Next week, you're going to give us all the efficacy data and all of that. So this was a part 1. We're going to come back for part 2. Anything we missed about mechanism, anything that came out of the consortium?
I think we covered it.
We covered it.
Yeah, we got it.
Sounds good. Well, join us for part 2. And it's really exciting to have just like really actual, like real life doable treatments that we know are going to work, are not going to be irritating. And the effectiveness is there. So that's what we're going to talk about. The effectiveness next.
Yeah.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.